Thank you very much. As was noted, I'm from Missouri, and if you looked at the map of the geographic disparities in the United States, you saw right in the middle of the country there was a very dark red state that is proud to have the lowest tobacco tax in the United States, in spite of our lobbying to the contrary. I always try to put in this disclaimer: I'm not only not current, I'm not even immediate past, I'm just past as it relates to the U.S. Preventive Services Task Force, and they want you to know that you can't trust me to totally represent their opinions. Almost everybody, I'm going to spend a minute on 2 minutes worth of USPSTF, which, by the way, you have to practice for about an hour to be able to say that, USPSTF. You can try that at the break. I'm assuming most of you are aware the U.S. Preventive Services Task Force is an independent, we like to say that, true, volunteer panel of national experts in prevention and evidence-based medicine. And the task force works to improve the health of all Americans by making evidence-based recommendations about clinical preventive services. We start with an analytic framework that links asymptomatic people on the left to health outcomes on the right, not intermediate outcomes. And from that analytic framework, you can see that we pay equal attention to the harms as we do the benefits. And every one of those numbers on there would become a key question that is systematically searched, not by us, but by people whose day job it is to actually search the literature, the evidence-based practice centers. We then address the evidence across the analytic framework. We judge the certainty of the estimate of both benefits and harms, and then judge the magnitude of net benefit, that is, benefit minus harms, to determine the magnitude of net benefit. Importantly, if we don't have what we consider to be moderate certainty from the evidence, we give it an I, insufficient evidence. As best I can tell, that's unique among all guideline panels, maybe on the planet, but certainly all the ones with which I am familiar. They do not incorporate expert opinion. That's not to say there isn't judgment involved. If the evidence is sufficient, we assign a letter grade A, B, C, or D, which looks like this. On the grid, down the left side, you can see the certainty of net benefit, either high, moderate, or low. You can see right away if the certainty of magnitude of net benefit is low, it gets an I, insufficient evidence. And across the top, you see the magnitude of net benefit, substantial, moderate, small, 0, or negative, and of course that is a judgment. For example, if the certainty of net benefit is high, that the magnitude of net benefit is substantial, that will get an A. Lung cancer. You already know this. It's the leading cause of cancer-related death, and I put the number at about 160,000. It is tobacco-related in 85 to 90%. And this is the combined curves, of which you already saw the racially and gender-separated curves. And I make two observations about this. The top line is, in fact, the red line there, which looks kind of red, is incidence, and the bottom line is mortality. I came to Washington, D.C. to show you how close the red and blue can actually be. And for 40 years hasn't really changed. The second, which Barry already noted, that we have made very little, honestly, strides in this disease once it's diagnosed, and that that top of the curve and the downward trend almost assuredly reflects tobacco control. Screening for for lung cancer with chest X-ray. That's important because we're going to talk about the NLST, and the control group was screened with chest X-ray. It doesn't work. That's sort of the bottom line. Although I was not practicing in the 50s, in spite of my appearance, I am told and have read that that is, in fact, when chest X-ray screening had its beginnings. And it had its beginnings because people were getting chest X-rays for tuberculosis, and as part of a tuberculosis surveillance and screening. And they noticed that when they did that, they were picking up small lung cancers. And in fact, there was a significant stage shift. We saw many more small cancers than we were in the cancers that were being clinically detected, and thus launched the 50 years of Let's Screen with chest X-ray. The trials reviewed by the task force include these two: the Mayo Lung Project, the PLCO, which went from 1993 to 2001, enrolled about 150,000 people from 55 to 74, but it was a general population as opposed to specifically high risk. There was a high risk subgroup, and they had 13 years follow-up. It was judged by the task force to be a good quality study. And the relative risk of having lung cancer was 1, and the lung cancer mortality rate was 0.94 with a wide confidence interval across 1 there. Therefore, chest X-ray is not deemed to be an effective screen for lung cancer. So what about screening with low-dose CT? Maybe it's better. There were 4 of 7 randomized controlled trials with published results in both arms when the task force reviewed these data. NLST, Dante, DLCST, and mild. We decided to not wait on the other 3 trials. That's a point of interest, and I would say that probably the most important trial that's out there right now is the Nelson trial. It is still quite small in comparison to the NLST. We appreciated that we could be confronted with what we were confronted with in prostate cancer, actually, which was a divide across the ocean in terms of whether there's any effectiveness of screening, but that even if Nelson came out negative, it probably would not trump the NLST in terms of its findings. I would also like to point out that Dante is an Italian study, and it's like the coolest name for a study ever, right? I mean, we come up with things like NLST, and they come up with Dante. We agreed that we should not let mild influence our decision. We really thought there was something peculiar going on with randomization in that trial. And we, in fact, contacted the investigators and concluded there was something peculiar going on with randomization in that trial, and we tossed it out. Here's the classic meta-analytic forest plot. The size of the box represents the size of the trial. In other words, all people in a random effects meta-analysis are considered to be equal no matter what trial they're in. And therefore, you can see that the NLST is going to trump the other 2 trials. The Dante trial, with a wide confidence interval, has a point estimate that's very similar to the NLST, which is a 20% reduction in lung cancer deaths. The DLCST gives us reason to pause and reflect. It has a point estimate, although it crosses 1 in confidence interval on the other side of 1. The updated results, which were alluded to just a moment ago that Peter Bach brought to my attention very, very recently, shows that point estimate closer to 1 at this point in time. Probably more concerning to us when we deliberated was the fact that all-cause mortality in the DLCST was on the wrong side and of borderline, almost statistically significant. We had to really think hard about that. And the updated DLCST results, that has also drifted back towards 1, 5 years post-final screen. Nonetheless, we do see here in the NLST a statistically significant reduction in all-cause mortality. Having been on the task force for 10 plus 1 years, let me tell you how uncommon it is to show a statistically significant reduction in all-cause mortality for any preventive service. Think very close to never. It's not true for breast cancer. It is not true for colon cancer. It is true for statins, by the way. We're not here to talk about statins. But it does say, what's the difference between these 2 trials, which may show differences? You can see that the NLST was substantially larger, 53,000 versus about 4,000. But the other thing is that the criteria for entry for the DLCST were a lot more lenient. That difference in age right there with respect to lung cancer is important. And that difference in pack years right there with respect to lung cancer is important. So we are enrolling a lower risk population from the standpoint of age and smoking in the DLCST. Maybe that's the explanation. Lung cancer is important. Think about all-cause mortality here. In the 3 reference trials of high-risk smokers in the previous meta-analysis, in the control groups during the follow-up, we saw 3,078 deaths. 1,058 of those deaths, 34% of all of them, were from lung cancer. One's ability to show a reduction in all-cause mortality is dependent upon 2 things. Is the relative reduction really huge? Nope, it's not. Is the absolute risk really high, and therefore a small relative reduction is important? Yep, it is. Compare that, for example, to the RSPC, the European Prostate Cancer Screening Trial, where over the course of the long-term follow-up, we saw 20,000 deaths. 522 of them were from prostate cancer, 2.6%. Screening helps. From the NLST, put into numbers that sort of make intuitive sense, per 1,000 individuals in the target group, 17 will die of lung cancer over an average of 6.5 years. With 3 annual screens, we can avert 3 to 4 of those cancer deaths. A modest 20%, modest reduction, relative reduction. If you put that in a context of some other screening programs, think breast cancer, that's better than screening mammography, age 40 to 49. It's a little bit lower than age 60 to 69, and probably fairly comparable or a little bit lower than women age 50 to 59. The number needed to treat is a reflection there as well. There are harms. We looked at the false positive rate, diagnostic testing, radiation overdiagnosis, psychological harms, and incidental findings. Much publicized in the first round of screening, 1,000 people were screened and there were 250 positive screens. 96% of these were false positive, extraordinarily high false positive rate. And after 3 annual screens, that number went to 390. Now, if you look at the data across centers, there was actually some significant variability across centers. This is the average. A high percentage of these false positives resolved with subsequent imaging. Before we go to the rest of the slide, think about this now. This is going to be one of those critical points in implementation. And so you think, here I am as a primary care clinician, but I really am one of those people, by the way, say to my patient, you might have lung cancer, let's recheck in 3 months. Are you sure it's not lung cancer? You mean 100% sure? No. Well, you know, there's going to be some tense discussion. On the positive side, we have experience with that with breast cancer at this point in time. We routinely bring women back for callbacks. We routinely say, come back in 3 months, come back in another 3 months, come back in 6 months, and we get away with it. Of 8 of the 200 positive screens, on the other hand, want an invasive biopsy to show they do not have cancer. Of 17,000 positive results, there were 612 complications and 6 deaths after a diagnostic procedure. That is, let's be humble. Let us be humble about what we're doing. About 1 in 5,000 people screened who do not have lung cancer will die because they were screened. Let us be humble about what we're doing. But in contrast, 15 to 20 in 5,000 will have lung cancer death averted. Radiation. The important thing about radiation, honestly, LDCT is fairly low dose radiation. The diagnostic scans are not. The impact of radiation is both cumulative dose as well as time dependent. So if you start screening earlier, you're going to hurt more people than if you start screening later. And if you do a lot of diagnostic CTs, you're going to accumulate over time a lot higher radiation dose. Overdiagnosis, this is not in the task force recommendation because it came out afterwards. Pats et al. Reported that the probability of a lung cancer diagnosed on screening as an overdiagnosis is about 18.5%. The number of overdiagnoses to prevent 1 death is 1.38. I think these estimates are probably high, and I could spend the next 30 minutes telling you why I believe that, but I can't. Note that the overdiagnosis, i.e. the incidence rate in the European trials was substantially greater. The LCST that we just alluded to had 50% more cancers in the screen group than they did in our group. What about the psychological harms? The studies that were available suggested no significant impact on quality of life. Smoking behavior, no compelling data suggesting either better or worse. Some people say, well, this is an opportunity. We'll screen them and they'll quit smoking. Other people said, they're going to say, look, my chest is clear. I'm going to keep smoking. We couldn't find either of those things. 7.5% in NLST had clinically significant non-lung cancer findings, the bane of the existence of primary care physicians. We hate these. And we have some uncertainty about whether this is positive or negative. Modeling. Why model? We have modeled, probably in cancer more than anything else, though probably our most complex model just came out in terms of aspirin prophylaxis. We've modeled cervical cancer, breast cancer, colorectal cancer, lung cancer. Why? No trial data for any screening test compare screening across the continuum of age ranges recommended for screening to no screening. And they also don't compare screening strategies. There are no trials comparing occult blood testing to colonoscopy. There are no trials comparing, et cetera, et cetera. Sort of name your, choose your weapon. So we have modeled with a wide range, quite honestly, of belief. I like to say to audiences, this is math, and so 50% of you don't trust it. In this particular audience, I'm willing to drop that to 25%. I am actually kind of in the middle of this, which is that math is not science, and it is math, and what comes out is dependent upon what goes in. We have, I think, valuable information that comes out, but you have to have respect for what modeling can do. This is what an efficiency curve looks like. When I first got into modeling, they used terms like deep parameter and extended dominance, and I thought I couldn't go back to Missouri and talk about that because I'm pretty sure it's illegal. The efficient frontier along the x-axis there says, if you're going to do 100,000 screens, go straight up from that line, and when you hit that curve, that's the strategy you should use to save the most lives from those 100,000 and 200,000 and 300,000 and so forth. So something that falls off that curve, by modeling, there's a better way to use those scans in terms of prevention of mortality. Here I've blown up the middle part of that screen. You can see that green dot there is what the NLST basically did. Start at age 55, enroll up to age 75, not stop, but it was very close to stopping because they only went for 3 years, and they didn't have very many people pushing 75 in the trial. You have to have a 30-pack year history of smoking, and if you have quit, you have to have quit in the last 15 years. You can see that that particular strategy is dominated by those that are up on the efficiency curve. So here are some examples of what you get from some of those models, including the NLST and including some of those others that you saw on the efficiency curve. The percentage ever screened, starting at, and those numbers again, start at age 60, go to age 80. You have to have a 40-pack year history of smoking, and you're going to screen for 25 years after you stop. You're going to screen 13% of the population, and you're going to do and this is per 100,000 total population. You're going to do 171,000 CT screenings over a lifetime of screening. You're going to prevent 410 cancer deaths and gain 4,211 life years. That's what the model tells us about that strategy. As you go down the list here, you can see that we're screening more people, we're preventing more cancer deaths, and you compare, for example, the middle two tells us what 55, 75, 30, 15 versus 55, 80, 30, 15, which is on the efficiency curve. You're going to do a marginal increase in number of screenings, but substantially increased number of lung cancer deaths averted, 459 to 521. And that is because your age is where it happens. People are more likely to die of cancer the older they get. Does that mean you should screen till 80? Not everybody thinks so. This is the model that we ultimately chose. And let me just say, there was endless debate about this. If we were making the decisions basically on the model, this would not be the strategy. And if we were to make the decision based only on the randomized clinical trials, this would not be the strategy. We had to decide when people should stop screening once you get started. So if you get screened between 70 and 75, when should you stop? We said 80. And you can see the absolute numbers here. You can see the latter two columns show a range, and so the absolute numbers here are somewhat less important than the comparisons. And this gives you a sense of what the models tell us about risks and benefits. So we're going to prevent 497 lung cancer deaths. We're going to gain 5,250. I think that's quite fascinating, actually. The models are predicting that on average, people are going to live about 10 years longer by preventing a lung cancer death. Not 2 years and then you drop dead of a heart attack. And in the models, of course, people drop dead of heart attacks. That's how they work. 287,000 CT scans, screening, full dose, 43,000. 910 people are going to get a biopsy for benign lesions. We're going to overdiagnose 190 cancers. and we're going to cause 24 people to die just from lung cancer radiation-induced deaths. The models did not extend out, for example, to breast cancer. When you radiate the chest, we are radiating the breast, even though we try to protect them. So it was a B recommendation, moderate certainty of moderate net benefit. In adults aged 55 to 80 years who have a 30-pack year history of smoking and currently smoke or have quit within 15 years. Screening should be discontinued once a person has not smoked for 15 years or develops a health problem that substantially limits life expectancy or the ability or willingness to have curative lung surgery. Every comment in there, by the way, could be this source of a 30-minute discussion about all the discussion that we had internally and externally. This may have been one of the first times we actually put in an entire section on implementation. If we're going to do this, how are we going to do this? And the implementation caveats were that the NLST was a low-risk population. Seems like an oxymoron, low-risk smokers with a 30-pack year history of smoking. Well, but it's still true. As they go, it was a relatively low-risk population. Unfortunately, both the models and some of the other trials show that it's actually the higher-risk part of that population that benefits the most. Real catch-22 there. Smoking cessation counseling should be done. There should be shared decision-making. There should be standardization of LDCT screening and follow-up of abnormal findings, and we actually suggested there should be a registry so we keep track of what's actually happening when we screen. I was just kidding about the questions part. You don't get to ask those until later. Thank you. I think if Peter showed up, he's probably next.